So this is cases related to tubulointerstitial diseases. Okay, so let us discuss the case. It's a 56 years female, presented with ARF, acute renal failure. See, when they give the scenario like this, I purposely gave the scenario. So we avoided the signs, clinical features, and you should know what is the criteria for calling ARF. That is laboratory investigation finding. Okay, so because we gave it directly, it is a ARF. The patient is in ARF, and here they given a renal biopsy finding. What is that? They're telling that uric acid crystals, and they are asking, they gave 4 diseases, and they are asking what is the cause of uric acid crystal. Understand? So here you should know about 2 things. What are the causes of uric acid crystal and mechanism of uric acid formation. So without that knowledge, you cannot answer this question. Understand? So you should know that increased cell destruction, increased cell turnover will cause increased uric acid. So uric acid, and one more thing, actually inshallah when you go to other modules you'll know more about it. Actually uric acid is not excreted in urine. It cannot be excreted in urine. The component before the uric acid is the component which is found before the uric acid is, just remember it as X, actually it is xanthine. This is excreted in the urine. Okay, so what we give is, when the person is having increased cell turnover, we create that. For example, in cancer treatment, we destroy the cells, cancer cells, and we create increased cell turnover. So automatically more cell destruction, more uric acid is formed, right? But we don't want uric acid because it will deposit in the kidney. So what we give is, we don't want xanthine to become uric acid, because xanthine is easily go out in the urine. So what is the enzyme involved in formation of uric acid from xanthine is xanthine oxidase. Okay, so what we do is, we put a blocker for xanthine oxidase. Okay, so automatically uric acid is not converted. So then there is a drug name called allopurinol. Okay, so we give the drug, so automatically the uric acid is not formed, xanthine is excreted. So this is how we handle. If the person is in cancer treatment, we do this. We give a drug, allopurinol, so that xanthine is excreted, uric acid is not formed. But if the person itself having cancer, then automatically we will not give allopurinol. So automatically there will be more cell turnover, more cell death, more cell production. This goes for imbalance. Automatically they will get more uric acid. So in the choice, what are the causes? They given chronic hepatitis B, leukemia, and they given ulcerative colitis and rheumatoid arthritis. Okay, see, hepatitis B is an inflammatory condition. It is not going to increase the cell turnover. Ulcerative colitis is also inflammatory condition, and this is also inflammatory condition. Actually, if you see the abstractors, okay, all are closely related. You understand? All the abstractors are closely related, and this is completely away from the obstructor. It's a tumorous condition, right? So sometimes they give abstractor very close and the right answer away from the obstructor. It will make you more confused. You will drown within the obstructor. You will think that why they gave 3 inflammatory condition, so the choice will be around the 3 inflammatory condition. That's what you cannot think the psychology of the examiner. Okay, if you go with the psychology of the examiner, you will fail. Understand? So always go with the logic, okay, rational way of seeing the choices. So here they didn't give any signs and symptoms, they didn't give any clinical feature, or they didn't give any laboratory investigation. Just straight away they gave the case of acute renal failure. Okay, so you should know about what are acute renal failure, what are the signs of acute renal failure, what are the laboratory investigation acute renal failure, and they given the laboratory investigation. One is renal biopsy that shows uric acid crystal. So then immediately uric acid crystal causing acute renal failure, you should know this uric acid is damaging the tubular processing. So completely it is depositing in the interstitium and the tubules, so it is producing acute renal failure. So what are the causes of uric acid formation? So what are the mechanisms involved in uric acid formation? So these all the things which I explained, no, that could have been asked as a question. What is the treatment you use to avoid uric acid crystal formation? Allopurinol. What is the enzyme involved in formation of uric acid, in this case xanthine oxidase? What is the metabolic product in the formation of uric acid is excreted in the urine? Xanthine. You understand how they can twist the questions? So you should know about all this process, then only you can answer the question. If you know this process, whatever the question may be, you will know it. So here the question is directed towards the cause of the uric acid formation. So you should know in this condition which causes cell turnover. That is the principle. Increase cell turnover, increase uric acid. So this condition which causes increased cell turnover is leukemia. So nothing more. That's straightforward question actually. Understand? So this is how. Say, if you see as per handout, you will identify leukemia. Actually, if you know more medicine, this question will be more confusing. Understand? So this principle, if you go by this principle, you will identify the answer. However, the questions may be difficult. Okay, because they can ask only within this. They cannot ask away from that. They will ask more than that, but actually it's not to the undergraduate level. They will ask you what type of birefringents, if it is a postgraduate level, what are the other salt or crystal shows by refringents in microscopy. We ask for pathologist. If ask for residents in pathology. Understand? So we will not ask you much in related to the morphology here. You got the point? One second. Second draw. Second draw. Now this is a second case, 46 year. One second. Okay, 46 years old diabetic woman. See, diabetic woman. When diabetic woman, when you read itself, your brain should know what are the clinical features of diabetic, what are the investigations will be positive in diabetic, what are the complications of diabetic. This all your brain should be getting deep into the diabetic once you read that. Okay, so then so now next is they given some clinical feature, that is fever plus pain in the flank region. See, I tell you, flank region pain, costovertebral pain or loin pain, loin to groin pain, these are all representing renal pain. Okay, these are all representing renal pain, and the patient is having dysuria plus frequency. Frequency means she can't control the urine. Yes. Urine drops comes out. Okay, frequency of urine. Understand? Frequency means she is going she gets a urine feeling. So understand? So frequency of urine. Then another thing they found is urine examination finding reveals glucose. Okay, then glucosuria, that is, but no ketones, plus no proteins. What they are telling in this? There is glucosuria because of diabetic mellitus, but it is controlled because there is no diabetic ketoacidosis, no ketones, and even no proteins, which means there is no glomeruli is normal. Glomeruli is normal. This is how you have to relate the morphology now. So no protein, no ketones, no complications of diabetic in this case, and no glomeruli is not affected still. It is controlled, very well controlled diabetic mellitus, but she developed pain and flank pain and dysuria. Understand? Only this finding we have. Then microscopic examination of urine shows pus cells. It is as if it's a direct question. Okay, so pus cells you are seeing, and urine culture is E. coli positive. E. coli positive. So which of the following complication is most likely to develop in this setting? Okay, they are asking about complication in this setting, and in that complication, if you see all the 4 choices that are all related to the renal, then immediately you should know all the complication and morphological changes happens in the kidney in diabetic mellitus. So start from the glomeruli. If you don't memorize it, that's what. If you start from the glomeruli, okay, glomerular changes, in this case it is absolutely normal. Okay, and Tasnim, I will give the attendance 1 second. Glomerular changes completely normal. So there is no glomerular complication, there is no glomerular sclerosis, there is no nodular sclerosis, and the thing is the patient is not having any acute renal failure. They didn't give anything related to the renal failure finding. Serum creatinine, decreased GFR, nothing they given. Okay, so which means tubules are normal, interstitium is normal, and blood vessels there is no change because that would have been reflected as a decreased GFR, something like that. So nothing is there. Okay, so renal biopsy looks normal, but only thing is the pus is coming, and the urine culture shows E. coli. Okay, see, when pus E. coli is shown, then the patient has not been given any ARF history. Maybe they are hiding it. So you should know the morphological diagnosis they given. If you carefully see these 4 choices, they given any morphological diagnosis. One is benign nephrosclerosis, malignant acute tubular necrosis, necrotizing palpitis, hydronephrosis, crescentic glomerulonephritis. Okay, so these 4 morphology they given. One is ATN, necrotizing papillitis, then hydronephrosis, crescentic glomerulonephritis. With this condition, with this history, you can come to a conclusion: diabetic mellitus patient having pyelonephritis. So In pyelonephritis, you can see necrotizing papilla. Necrotizing papilla. Even in diabetic, you can see necrotizing papilla. So, if you consider any of these two things, also only the thing complication they can have is necrotizing papilla. So, you should come to a, what are the choices given? A, ATN, B, necrotizing papillitis, C, hydronephrosis. So, if they given a background of obstruction, you can write the complication is hydronephrosis. If they given a background of ischemia, you can write the complication will be ATN. So, they given a background of infection, so the complication, pyelonephritis complication may be necrotizing papillitis. So, this is the right answer. And D, they given crysenteric glomerularitis. Actually, here the glomeruli is absolutely normal because there is no history given of hematuria, but there is no proteins. So, in this case, the glomeruli is normal, there is no inflammation in the glomeruli. So, it is not a crysenteric glomerulonephritis, it is not a hydronephrosis, it is not a ATN. So, only choice is necrotizing papillitis. So, you should know how you are excluding it, why you are telling necrotizing papillitis. Okay. So, let us go to the, if you know, then it is easy. So, brain should know. Third case, even seeing that much of videos, that much of case discussion which we had, some students will not understand, because I personally feel coming and learning rather than seeing the video, it's a difference is there. Acute myocardial infarction patient. Okay, it's a very straightforward case actually. Acute myocardial infarction patient, it's the most commonest thing happens in the hospital. Okay, and he is recovering. Now he is stable. He came for a MI. Now that patient becomes stable. This is the bad thing happens to the patient. Okay, so MI patient becoming stable during the hospital. Actually, hospitalized patient going for acute renal failure is common. Okay, so now he is in hospital, right? So after 2 days, the patient, you can put it this in the Facebook, they will understand. His urine output drops. See, he is going for decrease in urine output, and here they given urea nitrogen. Usually they give serum creatinine, blood urea nitrogen is increased. Obviously, if it goes down, this will increase, right? So the patient is going for renal failure. The patient is going for renal failure within 2 days. So it is acute renal failure, and the oliguria presents for few days. Then this oliguria is becoming polyuria, was working polyuria, and discharged after that. Mashallah. So discharge after that. Understand? So it is a clear-cut case. No need to see the choices. Actually, what I want is where you girls has to be trained like don't see the choices. Okay. So read the case and don't see the choice. Get a close your eyes. Get a complete picture, and that you are dealing with the ATN. In this case, you are dealing with the ATN. Okay. Then immediately take 2-3 seconds. Bring all the ATN in your front. Understand? Then see the choice. Then whatever the question may be, whatever the choice may be, so it must be related to this. Understand? Immediately you can hit the diagnosis. Here they given benign nephrosclerosis as a choice. Benign nephrosclerosis. Okay. B, malignant nephrosclerosis. Okay. C, acute renal infarction. D, acute tubular necrosis. With this background, oliguria patient coming to polyuria, then discharged, which means he is been recovered and discharged. So in this case, it is a ATN. I'll change the case now. For example, the patient had a MI. After 2 days, the patient renal function is deteriorating and it is not recovering. In these choices, Come on, tell me what it could be. See, that acute myocardial infarction patient comes to the hospital as emergency, then he has been stabilized. After 2 days, his renal function is going down, and it's keep on going down, creatinine is keep on increasing, the patient died. What it could be? It is here in this given choice, only chance is acute renal infarction. Acute renal infarction. Because, or it could be malignant hypertension. Or it could be malignant hypertension, and this benign nephrosclerosis will not kill him. Understand? So, you understand? So, they given the abstractors. When you go to medicine posting, these all are close abstractors. Understand? So, you will understand more. Okay. So, now in this case, because the scenario is very clear, patient recovered and went away from discharged, which means he is becoming healthy and went out. So, it is ATN. So, if the background changes, for example, the patient is not recovered, died, and autopsy is done, so it is acute renal infarction. It will be acute renal infarction or malignant hypertension. So, or if the hypertension is given like 120 in diastole, then it is malignant hypertension. You all understand? So, like that, if they change the background, then automatically the choice of answer changes. Okay. So, this is what I want to discuss. So, I close the video.